So this is what it looked like yesterday.
Any voice? Okay, great. All right, we're
Is it
done.
working?
Yes.
All right, great.
All right, thanks.
All right. See
Okay,
ya.
bye.
Bye.
Thank you. Thank you for waiting.
Hello, everybody. Okay, so can I hide this?
Yes, you can hide.
All right, good. So today is, in many ways, what should be first part of any discussion of neurology, and that is to do with the neurologic history. Okay, it is easily the most sophisticated thing that you will do. It is the hardest thing that you will do. It is the thing that you will spend the rest of your life learning to do. This is the heart of neurology. It also, I'll just say, in this modern era, is one of the reasons that dissatisfaction is so high among neurologists as a specialty, and that is, this is why we went into neurology, and you don't have time to do it. Okay, so that is one of the biggest discrepancies for neurologists right now. Nonetheless, it is absolutely essential, and it is the difference between you and everybody else. It's not the exam. The exam to some extent, but the exam is a lot easier to learn. The neurologic history is much more complicated. It's first of all important to begin with a statement by Ray Adams, and that is from Adams and Victor, and that is that neurology, the diagnostic process in neurology, is two steps. Unlike virtually anything else in medicine, two steps. The first question is, what is it? And the second question, the first question is, where is it? And then only the second question is, what is it? So you don't go to disease entity or pathophysiology until you know what part of the nervous system is affected. And you think that you do that with the exam, but that's only a part of it. It's mostly through the history that you get that information. The other thing I want you to know is that the neurologic diagnosis, both where is it and what is it, neurologic diagnosis is an active process. You have to be on your toes and aggressively pursuing this as you do this. And the way that you do that, you need to get comfortable with this, is you are constantly making and testing hypotheses. Okay, that's what you're doing. You're making a hypothesis of the localization. If this is in the spine, okay, then, okay, if this is in the spine, then these are the symptoms that the patient has. These are the signs that the patient ought to have. If you see those, then you like it, okay? So you're also gonna, as I'm gonna show you on the next slide, you're basically gonna be functioning as a Bayesian statistician when you are functioning as a diagnostician, all right? So if this is located in the right parietal lobe, all right, then their weakness ought to be accompanied by difficulty with facial recognition or a neglect syndrome or something like that. And so by knowing all the things that are in that area, you start to ask for related symptoms. And insofar as they go, how do you know I do that? Okay, then then you start to think that the diagnosis is more likely, okay? And you don't think of your review of systems, we'll come back to all this, you don't think of your review of systems as a list of things to memorize, okay, and go through and complete so that you get higher billing. The review of systems is your chief weapon, okay? That is a weapon that you're going to use. So when I say that we are Bayesian statisticians, what I mean is just this. You estimate the likelihood that of this localization or of this disease entity. And then you conduct a test. And then depending on whether the test is positive or negative, it either increases or decreases the likelihood of that localization or diagnosis. That's what Bayesian statistics is all about. You start with a pre-test probability, you conduct the test, and then you end up with a post-test probability. And it's useful to think about your diagnostic process this way. And in that sense, every question that you ask is a test. Every sign that you elicit on exam is a test. The test is not an MRI or a CT scan or a lab test. Your questions are tests, as we'll go over. And when we talk about diagnoses, you're always talking statistically. Okay. Well, this is, you say, well, could it be this? And I say, absolutely, it could be that, that's okay. Or I say something like, well, I don't know, that doesn't seem very likely. Or you go, well, I mean, I guess it's conceivable, but okay. But aren't those all statistical statements? Aren't I conveying to you a level of my certainty or the level that the likelihood that I think for that diagnosis? We do it all the time. If you'll say something like this. Well, if he's got spinal cord disease, he's going to have some degree of urinary dysfunction, right? And that's what we say. What do we mean by We mean it's likely that he's going to. That's what we mean. Now, when you go to take a history, taking a history is also what makes neurology fun, but and that's what makes it's very challenging. So I often describe a patient's history as a William Faulkner novel. So William Faulkner, in The Sound and the Fury, he took 7 stories, and then he took a pair of scissors and he cut them up. And then he shook them all up in a box and he started pulling them out. And then he just started putting these fragments in order, okay? And that was the book. Okay, it was a completely random order. There was no punctuation. There was that demarcated a switch from one time frame or story to another. And you had to, as you were reading the book, all 7 stories and their time frame gradually emerged. If you take an unstructured history from a patient, that's what you're going to get. That's exactly what you're going to get. You're going to get a series of stories that are all lumped together with no regard to the time frame in which the information occurs, and you will be stuck reading a William Faulkner novel. And that might have been fun once. I wouldn't want to do it again. All right. Another way that I think about these stories is that it's like a woman's drawer, my mother-in-law's top drawer of her dresser. She's got about 8 strings of pearls in there, which were not even clipped. And they're all entangled. They're all completely entangled to one another. You can't see where one ends or where the other begins. Your job, when a patient comes in like that, and Stephen's patient today was a good example, okay, is to take those strings of pearls, which are all tangled up in one another, and begin to follow one string at a time until you got the string there, and then you lay it out. And you get another one out, and you start to lay that one out. And pretty soon you see the relationship. Well, was this string of pearls did you already have this in the drawer before you put this one in? Or, which one came first? How do they, time-wise, interact with one another? Okay? That's what we're going to be doing. So the patients have all the information. What makes neurology really fun, in my opinion, is that the patient has experienced the problem. They know what the problem is. They've come to you for a specific problem. I can't sleep. I have weakness. I have numbness. I have a tingling feeling here, right? Stuff like that, okay? But they don't know how to describe it, and they sure don't know what it's due to. They haven't drawn correlations for the most time, and that's what you're going to do, okay? Their words often do not mean what you think they mean, and you need to be really careful about that. And the best example that I know of is a Bell's palsy. Now, virtually every patient I've ever taken care of with a Bell's palsy comes in because of numbness on their face, okay? There are no sensory fibers to the face from the facial nerve. There are none. I don't know what the hell they mean, okay? But they all talk about numbness on the face, okay? Maybe it's the slackness of it that they feel. I really don't know. But then you take out the Q-tip and they have no sensory deficit, okay? They can't have a sensory deficit. There's no sensory fibers in the facial nerve, but they'll all say numbness, okay? There are lots of other examples, and we'll go through some of them as we go. And so you need to understand what they're saying, okay? So when they use a word, that word will usually have importance to them. You don't say to them, I've never said to the person with Bell's palsy, oh, it can't be numbness. You don't have numbness. You don't have any facial. I don't do that. But I don't know. I got to figure out what they're talking about. Then once I know what they're talking about, I use their word, but now I know what they mean. Okay. There's going to be lots of words like that. Balance, sharp pains. What do you think a patient means by sharp pain? What do you think a patient means? If they say the pain is sharp, what do you figure they mean? Yeah, it's a bad pain. This is a bad pain. Okay, that's what they mean. Is that what you would mean if you asked a person, is this pain sharp? Do you mean, is this a bad pain? That's not what you mean at all. You mean, is it knife-like, right? So that's how you're going to ask about sharpness. You're going to ask whether the pain is knife-like. Does it feel like a knife or pin sticking into you? That's sharp. But the patients aren't going to say. So for their sharpness, we use a 0 to 10 scale, right? And we separate these things. But if you don't separate them, you're never going to know what they're talking about. And they will confound you over and over and over again. Now, here's an aside. We're talking about taking a neurologic history. So first of all, you have to create an environment in which you can get the neurologic history. Because you're not just going to get it any old time. You're going to ask them to open up to you. You're going to ask them to be patient with you. So there are all sorts of things that you need to do. So the first thing is, in the olden days, we used to go get our patients in the waiting room. Now you typically come into the room or switch rooms or that sort of thing. But either way, when you approach a patient, okay, like, okay, hi, I'm Dr. Newman, nice to meet you. This is a big deal right here. Okay, this second has a vast amount of information in it. Okay, how friendly are they? What's their attitude? Steve and I had the husband or Maria's patient. That husband was Maria here. She came along. She had so at any rate, you're going to get their attitude. You're going to get their willingness to participate. You're going to get a lot about their strength, a lot about are they depressed, are they that sort of thing. The husband of your second patient was
ignore.
Yeah,
That's
it
the
was
best
like,
thing.
wow. Okay. Anyway, we'll come to spouses in a minute. Okay. When I start with a patient, I tell them, I say, hi. So first of all, I get more. Let me also say that week by week, I continue to evolve. I haven't hit a static period yet. My practice with patients today is different than it was a week ago. I keep evolving. Right. One of the things that's evolved over the course of this last year is I keep getting more and more transparent with the patient. And I say, hi, I'm Dr. Newman. Your doctor sent you here because you're having difficulty sleeping. So I'm going to talk with you. I want to talk with you about the problem that you're having sleeping. That's what we're going to be doing for a while. Or, of course, you have the seizure short. And so all these questions I'm going to ask you for a while are going to be related to this, okay? I also say, and I say, I ask a lot of questions. Now, they look at you and they go, good. They like that you're going to, because they want this out there. They do. They want it understood. They're not hiding. In most cases, they're not hiding. They like someone who's going to take the time to hear their story. But they think that they're going to tell the story. We'll come to that in a second. And that's not the way I do it. I'm going to ask a lot of questions. So I warn them and I say, I could wear you out with questions, okay? And I'm going to come back to that because after about 5 minutes of asking questions, okay, I just stop and I look at them and I smile and I say, I told you I was going to ask a lot of questions, right? And they go, that's all right, doc, okay? But I have acknowledged that they are a person behind all these questions, that they're not just a source. This is not a Gestapo interview, which you need to avoid when you're going to be asking a lot of questions. You can get in. I've heard patients tell me that it's like being interviewed by the Gestapo when junior residents go in sometimes and start this approach without acknowledging that this is a lot of work. It's going to be, and sometimes I say, if you need a break, let me know, and we'll just slow down for a little bit here. So I'm interacting with them as a person, which is what this is about too. When you first, I believe that we act with our patients. I sometimes say, no patient has ever met me. They have no idea who I am. They don't need to know. It serves no purpose. Okay? I am, for each patient that I take care of, the person that I think that they need me to be to get well. I want to be that doctor that they need. Okay. Now, the when in Rome comes, you say, when in Rome, do as the Romans do. All right. But the question is, when on the first day when you arrive in Rome, what do? How do you act? You've never been to Rome before, and now you're supposed to act the way the Romans are. Isn't that's a lot of fun, I think. It requires a lot of extracting of information real fast about the patient and what they'll tolerate and what type of doctor they need you to be. That's got to be the first thing on your mind, is how you're going to establish that rapport with them. Now, you're always going to start with the chief complaint. So your doctor told me you're here because of sleep. So let's just talk about this. I mean, so as far as sometimes I'll say this, as far as you're concerned, why are you here today? What are we going to help with? Okay. So you can't say, why are you here today? Because they say, well, that's what you're going to tell me. Okay. And it also is a bit putting off. My wife didn't like it when I tried that out with her some years ago. And so that's when I switched and said, well, you know what? So why are you here today? How can we help? She liked that. Sally liked that. So how can we help? You know, how are we going to be able to help you? That's what we want to do. That sets a good tone, right? And then the question is, and this is a debate that goes on forever, how long do you let them talk when they start their chief complaint? How far do you want to get into this William Faulkner novel? Okay? Now, every once in a while, you'll hear a patient come in, usually an intelligent person, educated or not isn't the issue, but intelligent, and they know the story, and they did sort it out, and they start talking, and they give you, and you can let that person run much longer, but much longer is probably about 30 seconds. Okay, that's long. Okay, because even if they're well organized and know what they're talking about, I've got questions about that. I'm sorry, what you said that you had numbness there. It's like, I don't know what she means yet by numbness. And so I'm going to have to keep going. What does she mean by numbness? What does she mean by numbness? What does she mean by numbness as she's talking? And I need to resolve this. I need to know what she means by numbness before I can hear her story. I mean, that's what it comes down to. For me to hear what she's saying, I can't be storing up questions in my head. I've got to be able to ask them. So short time might be 5 to 7 seconds, which is probably about the average of how long I let the person talk before I interrupt them. Okay, 30 seconds would be, wow, this an amazing historian if I let them go 30 seconds. I like to know what their prior health was. So after I let them, because I want to get a rough estimate and say, so if they don't tell you, this is, if they start and they say, well, I was, 3 weeks ago, I say, fine, I'm going to let them go another 5 or 6 seconds. But if they haven't said when it was, well, I'm here because I keep having this serious pain in my head. They say, well, okay, and just roughly, I do like just roughly. Well, when did it start? And sometimes I'll say, I'll let you know if I ever need a precise answer. I'll let you know. Let's just, roughly. Because if you say, how long ago did this start? You know what they do? They take out their phone or their book and they start looking it up. Well, let's see. My daughter had to go to school on. Okay. You don't want to get into that. Okay. So answer is roughly how long we're talking about. Now, here's a device that I used today with someone that I do this stuff all the time. And they say, they give you another qualitative answer. Oh, it's been going on forever. Oh yeah, I've had this forever. And you go, and if they say forever, I go, 20 years? They go, 20 years? No, okay, maybe a month and a half. Okay, something like that. So the technique, these are techniques now that we're talking about. The technique, if you want a quantitative estimate, and they won't give you a quantitative estimate, give them an absurd estimate. Do it on purpose. Give them a totally absurd number. They say 20 years, and sometimes they'll go, well, it could be 20 years. Yeah, you go, okay, that's fine. Okay, most of the time, you're just giving them a sense. By giving them an absurd estimate, you're saying, I have no idea what you're talking about. Correct me. Help me out here, okay? And they'll go, oh, no, so, okay, fine. And they give you an estimate. That's which was what you asked them to do in the first place. Okay, so you need a rough estimate. Okay, so I don't know, maybe 3 or 4 weeks now. Good. Okay, fine. Now I want to know what they were like before that. So I say I give them. I put a little buffer in there. So I wouldn't say, okay, well, 4 weeks ago, did you have this? How were you 4 weeks ago? No, I really wasn't feeling very good 4 weeks ago. It's like, I know you weren't. So I shouldn't have asked it that way. If they say 3 or 4 weeks, I'll go back maybe 6 weeks or 8 weeks. And I talked somewhere about setting an anchor. So an anchor it's a time anchor. So it's really good to say, okay, well, what are we in? We're in July. How were you at Easter? Easter, yeah. Did you go out with, did you meet with your family at Easter time? Yeah, we had a nice, okay, well, how were you then? Did you have this then? No. Well, okay, so if I had met you, I love this question. If I had met you at Easter time, and for some reason I asked you, how's your health? What would you have said to me? I love that question, okay? Nice and open-ended. And I would go, yeah, good, okay? So I'd say, excellent, okay? Listen to the inflection in my voice. Excellent? Yeah, great, okay? I've got a healthy person. I might clarify, not being followed by a doctor for any medical problem, not on any medication. Nope. Now I have a healthy person at Easter. I can start. Okay. So then let's just stay with this healthy person. All right. Okay. So then so good. You were good. Then what was the first thing that happened that was wrong? Well, actually, I didn't tell you, but I was in a car accident. Do you think that might affect my headache and neck pain? I didn't mention it was a minor. So, okay, all right, stuff like that. That's the kind of stuff that goes on. We could spend an entire afternoon. How about a school bus teacher who has a headache? Okay, and you say, is there any pattern to the headache? And they go, yeah, okay, well, I don't want to get into it, but it's a school bus teacher. She never has a headache on Saturday or Sunday. She starts her day and she has no headache. By 3:30 p.m., she has this driving headache. And I say, when do you drop off the last kid? And she says, yeah, around 3:30, maybe a little bit before that. And you just look at her in amazement. It's like, are you kidding me? You're driving a school bus with 25 kids running behind you, and yeah, it's like, oh my Lord, it's okay. Anyway, so I like to get to what their health was. Now sometimes you'll go back and say, well, how were you at Easter? And they go, yeah, it was pretty good. Okay, pretty good begs another question. Well, pretty good doesn't sound perfect to me. So could you just tell me, what were some of the medical problems you were having back then? Well, and you start getting a list of stuff of what's going on. And I just make a catalog. I don't explore them very much, okay? But I do like getting the past medical history. I will say that. I like having the past medical history before I start the present illness. Well, maybe they're had a newly diagnosed cancer. Maybe they were started on chemotherapy, and they don't associate that with the tingling in their feet. I mean, why should they associate that with tingling in their feet? This is the problems in their shoulder, not in their feet. So, I don't get it. Okay. So, but I like to know their past medical history. You have to be careful. Sometimes I will spend too much time on certain elements and say, finally, when you spend 5 years with when you go over the 5-year history of the spine trauma that they had, you find that 5 years later, they were completely back to normal. They were 100% fine, in which case I wish I hadn't just spent 6 or 7 minutes exploring their spine injury with them. Okay. I say this all the time, and I believe this, that if you're going to understand the problem, I don't care what the problem is, if you're going to understand the problem, you have to understand it at the beginning. And if you do not understand the beginning of the problem, then you don't understand the problem. I believe that. So you're going to have to get to the beginning of the problem. Do not start in the middle, okay? You have to define when they did not have this problem. And so then I start to say to them, okay, so, well, okay, I'll give you a great example, okay? A guy is referred to me, I'm at Wisconsin faculty. A guy is referred to me because he developed left arm numbness following surgery on his something or other. I don't even remember. I think it was an orthopedic procedure. And he developed, and it wasn't related to his arm, and he developed left arm numbness after. Okay, so, what would you think? The positioning injury, right? Something like that. Okay, so I said to the guy, okay, well, just give me a sense for when this started. And he said, right after the surgery. What does that mean to you? So I said to him, okay, do you remember waking up in the recovery room? And he goes, yeah. I said, well, did you have it then? And he says, no. I said, okay, well, like when you went to bed that night, did you have it? He goes, no. I said, when you woke up the next morning, did you have it? No. When you left the hospital, did you have the numbness in this arm? And he goes, no. So I'm sorry, when did this develop? A couple weeks ago. My surgery was 3 or 4 weeks ago. I mean, I figured it was related to it. The surgeon doesn't even ask him, okay? He says, well, this started after your surgery, and he refers him because he's got this numbness or tingling after his surgery. I mean, okay? You can't rely on a non-quantitative estimate. You have to get back to the beginning, okay? Or you won't understand the problem. I really mean that. I might have passed let me just go. Yeah, okay. Here, I should have said this back then. So someone once did a study looking at the difference between the practice of senior neurologists and junior neurologists. This was literally a study that was done. And so absolutely no difference in the neurologic exam. No difference on any test-based knowledge that they could derive, okay? No difference there at all, okay? There was only one thing that differed between senior neurologists and junior neurologists, and that was the amount of time spent on the chronology of the present illness. A senior neurologist drills this to death, and the junior neurologists fly over it, okay? And the longer you practice, the more you're going to slow down and spend time on the chronology of the present illness. That's where the answer lies, okay, in most cases. All right? Now, you're also going to say, so you're seeing someone who's 42 years old, okay, for headache, okay? And so you're thinking, you listen to the description of the headache and you think, boy, this sounds like migraine. 42 is a little late for onset of migraine. I wonder if she's ever had headache before. So you say to them, well, have you been bothered by headaches in the past? And they go, no. We'll say, well, how about when you were just starting to have your menstrual periods? It's a high frequency time for onset migraine. Did you have it then? Not really. And then I take out what I call implied skepticism. So you're telling me that you never had one of these headaches like this one before? I'm really putting it to them. I'm going, this doesn't, I'm letting them know, this doesn't compute. I'm going, implied skepticism. You never had this before? Okay, I mean, maybe I had it twice when I was a teenager. Okay, twice, I'm getting them every other week now. But I've just made the diagnosis of migraine, okay? So it's but they don't see it that way. So the implied skepticism is an important thing. You'll do that in MS too. So, you never had any numbness or tingling, you never had any visual disturbance. Now sometimes they say never. They look at you and go, never. Oh, okay. I just want to make sure. Okay. So, but you use this technique, the inflection in your voice of implied skepticism, I can tell you, more than once has been a useful thing for me to do. Now, sometimes, especially at the beginning, but including to write today, okay, sometimes you're just not hearing what the patient's saying. It's not making any sense to you at all. No matter what hypothesis you make in your head, you cannot make this story fit. So what I do, and this is what I recommend and do myself, is I take out this mnemonic aid of OPQRST that comes from DeGowan and DeGowan, a father and son team from probably 70, 80 years ago, and I added O. And the P, okay, PQRST. So I just go through this entire list and make sure that I understand the OPQRST. So P are palliative and provocative factors. What makes it better and what makes it worse? Q is the quality. What's the nature of their complaint? R is the region. S is the severity. And T are all of the temporal relationships. Okay. O is other. What are the associated findings that are there at the same time, which they're not complaining about, but which come at the same time? So okay, so that's OPQRST. And when you want to start, if there are a series of events, you spend a lot of time on the first event, and then you spend less and less time. The easy question after you have a clear definition of the first event, but clear, what were they doing? Okay, how did it start? What was the first thing they noticed? How long did it last? I mean, we did that today. Okay, once you get that, then the next question is, has it ever happened again? Yes. Okay. Well, how many times altogether has it happened today? That was a question that I thought was useful today with your patient. How many times had she passed out altogether? She turned out, we were seeing a lady for syncope. She's been passing out since the age of 14. Okay. I mean, that wasn't obvious until we went and got that history. Okay. She's passed out 10 times since she was 14. Okay. And we're trying to figure out why she's passing out. You know, it's been there for 50. She said, I've been passing out for 50 years. She said to us, it's like, okay. Now, here's the thing, and this may seem obvious to you, but when you are talking to them and asking about a symptom complex, and it's going to have multiple manifestations in this symptom complex, you need to keep saying to them when you mean. Okay, so I did this today. You say, well, so we're talking about February when you passed out, right? And I'm saying, so in February, when you passed out, did you have any warning that it was coming? So when you passed out in February, what were you doing right before you passed out? And I kept saying, in February, when you passed out, and I kept saying it to them. Because the very first time I don't say that, you're going to get an answer that you don't understand because it applies to a different Faulkner story. They jumped ship. Okay, as soon as you let them, they're gone. Okay, they do not. You think I have just asked 10 times in a row about the syncope in February. Okay, and it doesn't even occur to you to say again, I'm talking about the history in the syncope in February. Okay, it doesn't even occur to you. You assume since the last 10 questions were about that time frame that the next one is also. They don't. It doesn't matter. They go, you know, I had terrible pain, and you go, terrible pain. We were talking about passing out. No, I mean in April when after I passed out in April, God, and I hit my tooth, and you go, that's what you get for not telling them when you mean. And so it just. I know these things sound crazy, okay, but this is the way you have to control these things. We're losing our audience here, so let me talk about this mini review of systems. So a mini review of systems is, are the symptoms, say, of Parkinson's disease, all right? So a person comes in for tremor. Tremor is the problem. It could be an essential tremor, could be Parkinsonian, could be intention tremor. We saw some of that yesterday, all right? Now, you make a hypothesis in your head, right? And you say, well, tremor could be from Parkinson's disease, right? So then you say to yourself, well, if this is Parkinson's disease, then the tremor ought to be at rest. They ought to be slowing down. It ought to take them longer to get dressed in the morning. They ought to have a shuffling gait. Their handwriting ought to be smaller than it used to be, right? And so that's your mini review of symptoms. That is a disease-specific review of symptoms. These are the symptom complexes that are associated with this disease. This is what you're learning. This is what you're reading in the literature. These are, or in your book chapters. Now you take that out and you say to yourself, well, so you ask them, if this is Parkinson's disease, so you say, well, do you find yourself slowing down in the morning? And this is where you become a Bayesian clinician, right? So because if they keep saying yes, how do you know? Why do you ask about my handwriting? Yes, as a matter of fact, it's so small that no one can read it anymore. okay? To each yes that you get, the likelihood of the disease of that hypothesis becomes greater and greater. And each no that you get, it becomes less and less. So that's a mini review of systems, and that's what I'm talking about. Now, and I think we'll come to this, we'll look at this one as an episode of loss of consciousness as a partial complex. Now, this is where it becomes even more useful to think about a question as a test. Every test that you'll ever do is associated with a sensitivity and specificity. So are your questions. And here's the cool thing. In almost every other test that you'll ever run, any change in the threshold that makes it more sensitive, okay, will also make it less specific. You're always trading sensitivity and specificity, okay, in tests of that kind. But the neurologic question and the neurologic exam is one of the only places I know where the art of medicine and the art of neurology is such that when you learn to do this correctly, you will simultaneously increase the sensitivity and specificity at the same time. That's unique. So I'm going to give you an example, and I'm going to take this out of epilepsy. So a person comes in because they passed out, right? You make a hypothesis that because it was syncope, they've already been to the cardiologist, it was negative, they don't have a change in their blood pressure, and you're thinking, well, this could be partial complex epilepsy, right? So you're going to drag out the review of systems, the mini review of systems for partial complex epilepsy, which includes, okay, clonic movements, unexplained sensory disturbance, all right? Of course, they may have been doing this for some time. That's another matter. But then you're going to ask about hallucinations, right? And you have, auditory hallucinations, you have visual hallucinations, you have olfactory hallucination, and deja vu. That's your mini review of systems for partial complex epilepsy. Now, if I start like this, so I say, picture a person, okay, who has been having auditory hallucinations. They've been hearing voices. Right? Okay, this has been going on for 1.5 years now in a 19-year-old prior to this first episode of loss of consciousness. Okay, I want you to put yourself in their position for a minute. What do you think? You're that 19-year-old, okay? What do you think's going on? You've been hearing voices intermittently, and you know you're hallucinating them, they're not there. What do you think? You think you're crazy. You're schizophrenic. You must be schizophrenic. Schizophrenics hear voices. So I go to him. Are you hearing voices? What did I just do to the test? Okay, in terms of specificity and sensitivity, what did I just do? What's the sensitivity of that? Okay, you come there, just tell me about passing out and say, are you hearing voices? Huh? So they're figuring, what do they know yet, right? They think they're crazy, and I'm saying, are you hearing voices? So I think they're crazy. So what do they say?
No.
Not me. Okay, no. Who made voices? Never. So you've just screwed the sensitivity of your test. So then you have to, let's take the other way around. Okay, let's do olfactory hallucinations. I must have done this for 1 year before I got wise to it. And I say, do you smell things that other people aren't smelling? And they go, mm-hmm. Okay, tell me about it. I say, well, I have a much more sensitive nose than everybody else. I can smell. Okay, and I go, problem with my specificity here. Okay, now I have to learn to ask these questions in such a way. And this is just my example. But this is so what, how do I overcome this? So I say to them, okay, so I'm wondering, so I'm saying, I understand how you passed out, and I understand that it doesn't seem related to your heart or blood pressure, that sort of thing. You've never passed out like this before. So, I want to think about with you whether these could be a kind of seizure. Now, I know you've never had, major seizures. I get it, okay? But there are some people have in fact, the most common cause of most common kind of seizures is pretty subtle. So I'm just going to ask you some questions about epilepsy. Some of these questions are going to be really weird, but you can just put that up to me, okay? Ben Franklin says, if you have something difficult to say it, and then follow it with self-deprecating humor. It's Ben Franklin, okay? But that's just me, okay? So just bear with me. I put my hand up. If I show them a little bit of my palm, it means, hold on, I don't want you to answer yet. I don't want you to do anything. I'm not done yet. That's the way I stop people from responding to me. That guy today, by the way, did not detect that. The Sandler was, oh my God, we saw some weird people today, I must say. Anyway, this guy was, he was insensitive. At any rate, so I'm doing this. I'm explaining to them. So, and then say, well, okay, some standard questions. I mean, first of all, and I ask them about clonic movement. Do you ever, your arm just suddenly jump? Or do you ever, myoclonic jerks? How do you get the person to, do you ever just throw the pen across the room? And I show them throwing the pen across the room with my body and with my eyes and everything. And they go, that's been happening. You're going to hear yes to that question, as strange as that. And that's how a myoclonic jerk behaves. They fling the object that's in their hand. Okay. Or you get numbness or tingling. Well, how do you talk about numbness or tingling? Like when your foot falls asleep. I mean, the same sort of thing, but for no reason. You weren't leaning on it. You weren't crossing your leg. And then suddenly it's there, just out of the blue. We saw last week, right? Out of the blue. Who was I with last week? And the patients repeatedly use the term out of the blue to mean seizure. And you can ask them, is it out of the blue? They rarely use it for stroke. They use it for seizure. They say, it comes out of, they say, well, you're sitting there doing, what were you doing? Nothing. I wasn't sitting there, just out of the blue, this thing comes. Okay, so now we're getting to the vocal. First of all, I don't start when I say, now here come the weird questions. I'm telling them this, I'm going, here come the weird questions, okay? So first of all, some people with seizures have hallucinations. Okay, so I want to know, do you ever see things that afterwards you decide wasn't there? Now, I start with visual because everybody, when do you get visual hallucinations? When you drop acid or something like that. It's organic. It's not auditory. Auditory is psychiatric, okay? Visual is not necessarily. So I start with visual, okay? Then I go, well, and how about, do you ever hear things that aren't there? Doesn't have to be voices. I say this, doesn't have to be voices. It could be dogs barking, doors slamming, or I mean, it could be voices. Okay. Well, first of all, the voices of epilepsy are not the voices of psychiatry. If a psychiatrist, a psychiatric patient, and you say to them, "Are you hearing voices?" and they go, "I do," and you say, "Well, can you who is it that you're can you tell who it is?" And they go, "Yeah, it's my mother." And can you tell what she's saying? And, yeah, but I'd rather not discuss it. It's really not very nice. You go, okay. Just show a little sympathy and go, okay, that's all right. But the person with epilepsy doesn't do that. You say to them, well, okay, so all right, you're hearing voices. Can you tell who it is? And they go, who's talking? And you go, yeah, can you tell who's talking? And they go, no. And you say, well, can you understand what they're saying? You mean like understand, hear and understand what they're saying? No, I don't. No, it's just a bunch of people talking. Okay, that's the auditory. That's what you get in seizures. And with the olfactory hallucinations, the way that I solved that problem is that I said to them, well, I want to know if you ever smell things that other people can't smell, and hand up, don't answer. Okay, and I mean, so typically a very unpleasant smell like smoke or burning rubber or some weird garlic smell. So people say things like this. So people, when you ask that question, the husband whacks the wife who's been there, and he says, she has made me clean the carpets 3 times. Okay, there's nothing there, doc. Okay, or one guy once said to me, I said, yeah, and you wrinkle up your nose when you do this with him, and he goes, oh yeah, and you say, well, what's it like? And he goes, I don't know. He said, but I can tell you one thing. And I say, oh, good, what's that? And he said, it's not of this world. Just, that's the kind of stuff that you get. All right. Just very quickly, not that any of you have a problem with this, but you have to, these people come to see us for help. So treat them like a person. At Stony Brook, the first year of medical school, you learn to interview people without getting into any medical at all. You just interview them to find out what their life was like. That's what they do with the first year medical students at Stony Brook. Judgment has no place. You say that you have no judgment. I doubt that. When you're dealing with recidivism in alcohol, recidivism in use of cocaine and that sort of thing, it is natural to want to judge them. It serves no purpose. Okay, it doesn't help. Okay, it's just not something that's worth doing. I said before, you need to be aware of how you appear to them. And if I'm with you, by the way, in the clinic or in the inpatient, almost everything I do, I'm doing for a reason. And if I sit down, I definitely am sitting down for a reason. And usually if I say standing, unless there's no chair, I'm standing for a reason. If I cross my arms, there's usually a reason. Okay, if I touch the patient, there is a reason that I touch the patient. Okay, I don't do anything. And I want to get to this point too. When you are rounding with your attendings, and we have fabulous attendings. I mean, you just have some great clinicians in this department. When you're rounding with them, the way that they ask the question is at least as important as the patient's answer. So pay as much attention to the way that the attending asks the question as you do to what the patient says. Okay, it's important, but how they ask is important. Treat your patients with respect, and remember that our patients are. Yesterday, one of the patients said to us, as I was walking out of the room, I think it was Maria's patient. She said, "Damn, everybody here is so nice." You know, it wasn't just me. It was just nobody. I don't think anybody had ever treated this person like a person before. You know, they're just some being in the store. Nobody's nice to each other. And we were just nice. It was, all of us were nice. We were nice at the front day. She just loved it. I mean, and that's what right? I mean, everybody's so nice around here. Okay. I always make sure I do ask a lot of questions. I say it over and over again. We talked about the implied skepticism. You use your body. We're going to get into that in the physical exam as well. You need to use your body to communicate to the patient. You have to learn to do that. Interruptions are insane. And especially sometimes I ask patients as they come in whether they understand. I just confirm that they understand English. I don't want to be insulting. If they say yes with a bit of a, who the hell do you think I am? I said, I just say, I'm sorry. A lot of our patients don't speak English. I always need to make sure. It was nothing personal. I always need to make sure. Okay, something like that. Or if they say, yeah, yes, un poco, or something like that, or answer me in Armenian, I always just say, I'm sure your English, so we're good, because I'm sure your Spanish is better than my English. I mean, is better than my Spanish. So yeah, so thank you. I know your English is better than my Spanish. You need to be careful about false friends. We talked about numbness. Here's a good example. If a patient has a cerebellar deficit, right, and starts veering to the left, okay? So that's the setting. They have a stroke, they're veering to the left. What do you think that they come in and complain of? What's their chief complaint? Dizziness. They're going to talk about dizziness. And then you say to them, well, do you have vertigo? My hand? Don't answer. I mean, spinning or rocking. And I show them what I mean. No, I don't have any meaning. Yeah. Well, do you mean dizzy like if you stand up too fast, you get a little lightheaded or something like that? They go, no, I don't really have that either. Keep going. Well, there are others. We'll get into that another day. But eventually you say to them, well, do you mean that you're dizzy, or do you mean that you're just sort of off balance? You've lost your balance. You go, oh God, that's it. That's what I'm yeah, no, I'm not dizzy. I have no balance. Okay, good. So that's what I meant about finding the right word for the patient too. And all of these, that's why I did with the vertigo. It's like you have to show them the vertigo that you're talking about. We'll get into this another time. You need to use other observers sometimes in loss of consciousness, okay, in amnesia. I mean, you can't rely on the patient themselves. They may not have the information, literally, and so you've got to go get the information. Lots of different ways. Cops, EMS are always helpful. I'll just give you one example. I want to get this one straight. We're going to finish in a second. So the spouse, this again today, the guy who was standing next to me, and you do this with children. Let's take children as an example. So mom comes in and she's got the 4-year-old on her lap, okay? And mom wants to tell you the story, okay? Let me tell you something. You can interview a 4-year-old with the same level of detail that I can an adult. I have no problem interviewing a 4-year-old and getting all of the information, the same as you would in an adult. The only thing that changes is how you use the analogies for the child to define the words, because the child hasn't yet learned the words. Okay, but the adults haven't learned the word yet either. So it's really just a different level of analogy. And here's the problem. Mom wants to tell the story. Mom has no clue that little Johnny already knows the problem and just can't express it or hasn't had the opportunity to express it yet. So mom is telling you about what she has observed. As far as what mom is concerned is that the problem is the problem that she has observed. But that's not the problem. She's just observing how the kid is responding to the problem that he has. And you're not going to learn what the problem is until you get mom to be quiet. Okay? And that's going to happen with spouses all the time too. So I say to mom, I listen to mom. I need mom involved. For one thing, I need Johnny sitting on mom's lap so Johnny's not afraid of me. So, okay. And yeah, I don't want to disturb this caretaker relationship where the husband's been taking care of his demented wife for 2 years. I don't want to disturb that relationship. I need it intact. I don't want to disturb it. So I'll listen. I'm moving along because, okay, but I want to talk to the patient. Okay. And I haven't got a chance. So, or I want to talk to Johnny. So I say to them, I get that, okay? And what you're saying is really important to me, and I want to come back to it. I just need to hear what little Johnny's going to say. I just need to hear how your wife understands this, okay? So let me just talk with her, and I need to get her into a zone with a patient. I mean, when you get when you get all this right, it almost becomes intuitively simple. And you're in a relationship with a patient where you are following what they are saying, and they are following what you are saying. And now your give and take becomes really nice, and you're going to get your answer right then. But if they keep interrupting, that can't happen. So they interrupt, and I go, okay, thanks, but hands up, okay? Now I'm showing them my palms. I think I need to talk to your wife, okay? So let me just continue with her. Next interruption, I'll just go like this. Would you be, and I'll do this with parents, would you be more comfortable in the waiting room? And they sit back and they get it, okay? It's like, no more talking until I let you know I'm ready to hear from you. I don't want you to interrupt anymore, okay? That's one of the strongest things that I have ever said to anybody, okay, is would you be more comfortable in the waiting room? Because I can't do this while you're interrupting. That's what I'm saying. You end by telling them backwards what you heard, okay? And this is often your response, okay? Usually you get it right, or and sometimes they are satisfied. I would say more often, the majority of the time, they are glad that they've finally got the story out. Not that you were the only one ever to listen to them, but you're the first one to really hear the story from beginning to end. And they get it. That information is now it's permanent, it's memorialized, you're going to get it in there, and they can rely on that from now on. And that's very satisfying to them when that finally happens. Okay? That's a long, well, we started late. It's a lot. There's a lot in that, and your whole life is going to be spent learning to do that. That's what I would say. You're going to learn the exam long before this year is over, certainly before you leave your residency. You will not yet be accomplished at history taking when you leave the residency. It's something that is it's infinitely complex. There are only so many responses on the neurologic exam. The answers are infinite. It's literally infinite. Okay, so enjoy it. That's what I would say. Enjoy it. It's just great. And when someone says something like, "I can tell you it's not of this world," it's like, I love hearing something like that, where they're trying to convey to you something that cannot be conveyed in words. Okay? Good.
Thank you.
Yeah. Friday is the neurologic exam, and we will do that as a demonstration. So someone needs to come volunteer to do the neurologic exam. No socks.
You wanna do the
No
first?
socks.
No, yeah.
I gotta work on that. Maybe,
Easy, short, maybe short sleeves, and if you did you say you're going to volunteer? Yeah, so that's great. The short sleeves and no
We'll
socks.
stop it. We're not talking.
Yeah, Steve edits. It doesn't matter. He'll just chop it right on.
Oh,